All right, well, let's get right to it. I'd like to introduce Marat Fudim, who will talk a bit about autonomic dysfunction in HFrEF patients.
Thank you. Thank you for the introduction. I'll just jump right into it. I was tasked by talking about autonomic dysfunction. Not something we think about every day, yet we have now dedicated therapies to target autonomic dysfunction. So I'll start by the mandatory slide to review the autonomic nervous system in the body, which really maintains all the functions you don't think about it. Eating, sleeping, blood pressure, heart rate, all of these things are regulated by reflex loops. And the two major systems here are the parasympathetic, that's the rest and digest system, and the sympathetic, the fight or flight system. The baroreflex, the arterial baroreflex specifically, which was located in the carotid arteries anatomically, but also a little bit in the aortic arch, is one of the key mechanisms to maintain blood pressure and heart rate in a human being with daily activities such as exercise. If you want to stand up and your blood pressure to maintain stable, that's the arterial baroreflex that allows us to maintain blood pressure and heart rate. So it's vital. Yet in heart failure, it's exactly that baroreflex that has been demonstrated for decades now to be dysregulated. And specifically what it means is that the baroreflex sensitivity, which I will go over in a few minutes, baroreflex sensitivity is downregulated. That reflex is no longer as sensitive to changes in its environment as it is supposed to be. As a result, the sympathetic tone is high, the parasympathetic tone is down, and it has been strongly linked to worsening heart failure and heart failure symptoms, and I will demonstrate in the next few slides. So as I hopefully will demonstrate in the next few slides, and I won't be able to pack 50, 60, 70 years of research into a 10-minute presentation, but I will give you some of the high points. We do know that in heart failure, there's a strong association with a high sympathetic tone. You truly have high neurohormonal imbalance, so you have a lot of vasoconstrictor hormones, a lot of stress hormones floating around. It's associated with high filling pressures, worsening kidney function, and that then really translates to worsening clinical outcomes. That is pretty well established. So what is baroreflex sensitivity? So here's a thought experiment. If you to apply positive pressure on your carotid arteries, you trick the baroreflex to think that there's high pressure in the system. The result will be that your blood pressure drops. So now we can draw a curve that as the more pressure you apply, the lower your blood pressure gets, and that speaks to the sensitivity of the system. And there's a way to just dial it in with a special technology. And you can do the reverse. You can give vasodilators, and you will see how the body tries to overcompensate and vasoconstrict and increase the heart rate in response. That's all baroreflex. In heart failure, the baroreflex curve is flatter. That's a solid black curve. If you now extrapolate it and use it, show it in the bar graphs, you see that compared to controls, heart failure patients, or here CHF, has low baroreflex sensitivity. By the way, that's true for heart failure preserved, but also heart failure with reduced ejection fraction. But the majority of the data will be shown for heart failure with reduced ejection fraction. So now if you match up baroreflex sensitivity, lower is worse. With symptoms, you see that higher symptom burden is associated with greater baroreflex insensitivity. So the baroreflex is less sensitive the higher your NYHA scale is. But then if you take it to the next step and you say, well, what is the association of actual outcomes? And here we're talking about survival, not even heart failure hospitalization, actual death. You see that severe mortality is significantly higher the lower your sensitivities. Well, is this an association? What's the chicken? What's the egg? Well, that we can't give you for sure an answer to, but we do know that if you stimulate the parasympathetic nerves of the baroreflex that sit in the neck, that innervated by the vagal and the glossopharyngeal nerves, so cranial nerve 9 and 10 from your med school days, these are the ones that if you stimulate them, on the right side, you see that you can decrease the sympathetic tone. It can be sustained. This is human data. It can be sustained for 6 months. That's using the Barostim technology. But at the same time, if you to measure baroreflex sensitivity over time, that's the left figure, you will increase baroreflex sensitivity over time and maintain it. It actually increases with time. So there seems to be some form of learning. So we do know that it's associated with outcomes, and we can reverse that process, at least on that electrical level, and then feeding back to the brain, because this is a purely afferent reflex that gets integrated in the brain and then lowers the sympathetic tone on the back end. So to demonstrate it to you in a sort of more visual aspect, so this was initially tested actually in hypertensive patients. Hypertensive patients are known to have high blood pressure. And here, when you turn on the device here in dark on, you see that the blood pressure on top drops immediately within seconds, And the sympathetic tone measured via muscle sympathetic nerve activity, MSNA, in the peritoneal nerve. Not a friendly procedure to do to the patient, so we're not doing it on a regular basis. Sympathetic tone goes down within seconds, blood pressure goes down. You turn the device off, blood pressure goes up, sympathetic tone goes up. So it's really an on-off phenomenon. It doesn't always work like that fast in patients, but it tends to be within hours to days that you actually see those acute effects. So now, is this a novel concept to intervene with the autonomic nervous system? No. As a matter of fact, one of the earliest device-based strategies to be tested for cardiovascular conditions was by Eugene Braunwald here in the middle, but the lady on the left is Nina Braunwald. This is actually deceased first wife. She was a surgeon. She did actually the implants of what was the earliest form of baroreflex stimulation therapy back in the 60s. And back then it was an implantable device, way beyond where actually pacemakers. They already were doing external pacemakers for the baroreflex. And here you see in the middle the carotid sinus circle and right. That's the little nerve that comes up from this. This is the carotid sinus is where that nerve patch is placed for the baroreflex stimulation therapy. So what does the historic literature teach us? Because they realized back in the 60s that this might be a viable concept. So they've done it for patients with refractory angina. And what they found is that if you give it to people with refractory angina, some of them might have been heart failure patients, hypertensive patients, you didn't have many treatments back then, is that by stimulating those nerves, you were able to see acute reductions in heart rate and blood pressure with a symptomatic improvement if you actually exercise those patients repeatedly. So this, of course, was abandoned in the 1960s. It was a relatively morbid procedure back then. They then started getting access to medication therapy, and so that fell out of favor till you'll hear in the next sessions, and by the next speakers, we came then, to the early 2000s where we developed a new novel implantable technology. Okay, to summarize, I hopefully demonstrated to you that in heart failure, baroreflex sensitivity is down, sympathetic tone is up, hormones are elevated, so you can certainly reverse that. And I did not show you impacts on neurohormonal levels. There are data on that in animals and humans. I did not show you the impact on kidney function. There are animal data on that. So those neurohormonal imbalance does get restored to some degree, certainly not perfect, but that is the mechanism of action. And the next speakers will then hopefully demonstrate to you how that translates to clinical findings and clinical endpoints. Thank you very much for your attention.